Welcome back to the deep dive. Today, we are shifting gears completely. We aren't just analyzing a paper or chatting about a trend. We are simulating a high-stakes environment. We're doing a really specific, high-yield revision session. If you are an MD anesthesiology student, and specifically if you're gearing up for those Gujarat University exams, this session is, well, it's custom-built for you.
That's exactly right. We're going to strip away all the fluff. I want you to imagine we're sitting across the table from you, maybe in the hospital library, or, the duty room at 2 in the morning.
Right, with a stack of textbooks between us.
Exactly. And we need to structure the perfect answer for that dreaded viva voce, or that massive 20-mark theory question.
And the topic today is an absolute beast. It bridges surgery, medicine, critical care, and of course, anesthesia. We are talking about deep vein thrombosis, DVT.
Yep.
We're going to cover the etiology, pathophysiology, clinical features, prevention, and the holy grail for us.
Yeah.
The anesthetic management.
It is a staple topic for a reason. I mean, examiners love it because it tests everything. It tests your basic pathology, Virchow's Triad, and it tests your clinical judgment in the OT and ICU. It's a potential death trap in a Viva if your basics aren't rock solid.
So consider us your study partners for the next 40 minutes or so. We've pulled the key points from the standard texts. Robbins for pathology, Miller and Morgan for anesthesia, Stolting, all the usual suspects.
And the standard ICU protocols, of course. We're going to break this down exactly how you need to present it to an examiner.
Okay, let's do it. Let's treat this like a mock exam. We need to start where every good answer starts.
The fundamentals.
Part A, fundamentals. Let's set the scene. So the examiner, they look at you over their glasses and say, "Doctor, define DVT and tell me why I should care." How do we frame that intro so we sound like a consultant, not a first-year resident?
You need a crisp professional definition. You don't want to waffle here, you say. Deep vein thrombosis is the formation of a blood clot, a thrombus, within the deep venous system. And then you specify. Predominantly, we're talking about the lower extremities, the popliteal, femoral, and iliac veins.
But is it strictly limited to the legs? I feel like I've seen upper limb issues in the ICU all the time.
You have, and that's a nuance that gets you extra marks. You should definitely mention that. Upper extremity DVT is absolutely possible, especially in the ICU setting with central venous catheters or PICC lines.
Oh, boy.
But for the exam context, the focus is the legs, and you must immediately connect it to the wider clinical spectrum. DVT isn't an island.
It's the start of something worse.
Exactly. It's the origin point of venous thromboembolism, or VTE. You can think of it like this. DVT is the fire, and pulmonary embolism, or PE, is the house burning down.
That's a great way to put it. So why does this matter to an anesthetist specifically? Why isn't this just a surgeon's problem to worry about?
3 massive reasons. You have to list them. First, perioperative risk. In hip surgery, without prophylaxis, the incidence of DVT is like a coin toss. It can be anywhere from 40 to 80%.
That's a staggering number.
It is. Second, obstetrics. It remains a leading cause of maternal morbidity and mortality. And third, the ICU. It's a major complication of critical illness and immobilization. If you're managing that patient, you own the risk.
And we can't forget the exam format itself. How does this usually pop up?
It's everywhere. It's the classic 20-mark long answer. Discuss etiology, pathophysiology, and anesthetic management. Short note. Virchow's Triad or DVT prophylaxis. And in the Viva, it's always a clinical scenario. You have a patient with a fractured femur and a swollen calf. What do you do?
Okay, so you've set the stage. Now the examiner leans forward and asks that golden question. Tell me about the pathophysiology. If you don't say Virchow's Triad in the first 5 seconds, you've probably failed, right?
Essentially, yes, you're toast. Virchow's Triad is the anchor. You have to visualize that triangle in your head. 3 primary abnormalities that lead to thrombosis.
Okay, what are they?
1, endothelial injury. 2, stasis or turbulent blood flow. And 3, hypercoagulability.
Let's unpack these one by one because this is where the why comes in. This is where we add those little insights that make the answer shine. Let's start with endothelial injury.
Okay. This is often the trigger event. You have to remember that the endothelium is normally a non-stick surface, like Teflon. It actively prevents clotting.
How does it do that?
It's secreting things like nitric oxide and prostacyclin. But if you damage that vessel wall, you expose the subendothelial matrix, specifically collagen and tissue factor. And that is what kicks off the whole coagulation cascade.
And in our context, the operating theater, what are the specific things causing that injury?
Well, surgery itself is the obvious one. Direct trauma to the vessels during a hip or knee replacement, fractures, burns. But I want you to think about what we do as anesthetists.
Ah, like placing a central line.
Exactly, inserting a central venous catheter. Putting that large bore cannula into the femoral or internal jugular vein is direct endothelial trauma. Even chemical irritation, think about hypertonic solutions or chemotherapy agents, they literally strip that protective lining away.
So every single time we place a line, we are potentially initiating step 1 of the triad.
Precisely. We are part of the pathology.
Okay, component 2, stasis.
Right. Blood is meant to flow. It's a rheological necessity. Normal laminar flow dilutes activated clotting factors and washes them away to be cleared by the liver.
And if it just sits there?
If you have stasis, procoagulants accumulate locally. You also get local hypoxia, which damages the endothelium further, which then feeds back into the first point. It's a vicious cycle.
And looking at our daily work, anesthesia seems almost designed to create stasis.
It is. General anesthesia, spinal anesthesia, we induce paralysis, we knock out the muscle pump function of the calves. Normally when you walk, you squeeze those veins and push blood up against gravity.
Sure.
If a patient is on the table for 4 hours under a neuromuscular blocker, that blood is just pooling. In the ICU, it's immobilization. In heart failure, it's the pump failing, causing venous congestion. In pregnancy, it's the gravid uterus literally compressing the iliac veins against the pelvic rim. It is all about flow interruption.
Which brings us to the third corner of the triangle, hypercoagulability.
This is the chemical imbalance. And for the exam, you have to divide this into primary and secondary causes. Primary means genetic.
Like factor V Leiden.
Factor V Leiden, protein C or S deficiency, antithrombin III deficiency, all of those.
Is there a clinical clue for the genetic stuff? How would you pick it up?
Age and history. If a young patient, say, under 40, comes in with a massive DVT and no obvious trauma history, or they have recurrent DVTs, you have to start thinking genetics.
In the secondary, the acquired causes. This is our daily bread and butter, right?
Absolutely. Malignancy is the big one. Cancer cells release procoagulants. Pregnancy is a hypercoagulable state by design.
Right. The body's getting ready for delivery.
Exactly. It's preparing for hemostasis so the mother doesn't bleed out, but the trade-off is clot risk. Sepsis creates a pro-thrombotic state. Trauma releases massive amounts of tissue factor. All of these things shift the balance toward clotting.
So when you're answering a question on etiology, you don't just list risks, you have to categorize them under Virchow's triad. That shows the examiner you understand the mechanism, not just a laundry list.
Precisely. It turns a list into a physiological argument. That is how you get the higher marks.
Okay, let's move on. Part B, etiology and pathophysiology in a bit more detail. We need to talk about risk factors specifically.
Yeah.
If I'm writing a theory paper, I need to list these out clearly. What are the very high-yield risk factors we need to, bold in our answer?
You should break them down. Surgical, medical, and ICU. For surgical factors, it's dominated by orthopedics. Total hip and total knee replacements are the highest risk, no question. Also, major trauma and any surgery lasting more than 30 minutes.
Why is ortho so uniquely bad? Is it just the bone work?
It's the perfect storm of Virchow's triad. You have endothelial injury from the surgery itself, from the retraction. You have stasis from the positioning and the post-op immobility. And you have hypercoagulability from the huge inflammatory response to bone reaming and cement. Plus, these patients are often elderly to begin with. It hits every single risk marker.
And for the medical factors?
Malignancy is crucial. And there's a specific term you should drop in an exam, and it'll make you sound smart. Trousseau syndrome.
Trousseau syndrome.
Or migratory thrombophlebitis. It's often a sign of an occult, visceral, cancer-like pancreatic or gastric pregnancy, as we mentioned. And don't forget obesity and age. The risk climbs significantly after age 60.
Okay, and in the ICU, what's special there?
The ICU is a DVT factory. We talked about lines and sepsis, but think about the ventilator. Mechanical ventilation involves positive pressure. That intrathoracic pressure reduces venous return.
Of course.
It literally holds the blood back in the periphery. So the life support machine itself is a risk factor for stasis.
That's a brilliant connection to make. Now, let's get into the nitty-gritty of the clot itself. Pathophysiology. The examiner might ask, Doctor, is a venous thrombus the same as an arterial thrombus?
And the answer is an emphatic no. You need to understand the composition. Arterial thrombi, like in a heart attack or a stroke, they form in high-flow systems. They're platelet-rich. We call them white thrombi.
And venous ones.
Venous thrombi form in sluggish, low-flow systems. They are fibrin-rich, and they trap a huge number of red blood cells in that fibrin mesh. That's why they're called red thrombi or stasis thrombi.
And that's a key distinction because it completely explains the pharmacology, doesn't it? It explains why we use anticoagulants like heparin for DVT rather than just antiplatelets like aspirin.
Exactly. Aspirin targets platelets, which is great for arteries. But for veins, you need to target the fibrin and the coagulation factors. The pathology dictates the pharmacology.
So it forms typically in the valve cusps of the deep veins where the flow is slowest. What happens next?
Propagation. The thrombus grows. And it grows in the direction of blood flow, which is towards the heart. And the tail of this thrombus is often poorly attached. It's just sort of waving in the venous stream like a pith of seaweed. This is the dangerous part.
Because it can just break off.
Embolization. That loose tail fragments travels up the IVC through the right atrium, right ventricle, and lodges in the pulmonary arteries. That is the fatal consequence we're trying to prevent.
Okay, before we get to the fatal part, let's talk about what happens locally. Venous obstructions.
Right. The clot blocks the return of blood, so you get distal edema, congestion, and pain. But, and this is a massive physiological point, collateral circulation can sometimes bypass the block.
Which brings us to Part C, clinical features and diagnosis. What does the patient actually look like?
Classically, you have a patient with unilateral limb pain, swelling, warmth, and maybe some erythema. There's calf tenderness. If you measure the limb circumference, a difference of more than 3 centimeters compared to the other leg is pretty significant.
But here comes the exam trap. I feel like this is where students lose a lot of points.
Yes, the trap is relying on these signs because 50% of patients with DVT are asymptomatic.
50%.
Half of them. They have no swelling, no pain. The first sign of their DVT might be a sudden cardiac arrest from a massive PE.
So if the examiner asks, how do you rule out DVT clinically?
You answer, you can't. You can have a high clinical suspicion, maybe using scoring systems like the Wells score, but you cannot rule it out with a physical exam alone. And please do not mention Homan sign.
Ah, yes. The dorsiflexion of the foot.
It has poor sensitivity, poor specificity, and you might actually dislodge a clot by doing it. Examiners hate it. It's a relic. Forget it exists.
So we need investigations. How do we diagnose it definitively then?
Conceptually, you risk stratify first. If the risk is low, you might start with a D-dimer test. It has a high negative predictive value.
Meaning if it's negative, you're pretty sure they don't have a clot.
Usually, yes. But in our patient's post-op ICU, pregnant, the D-dimer is often elevated anyway from inflammation, so it has very low specificity.
So it's almost useless in the immediate post-op period, isn't it?
And pretty much everything is inflamed. So you need the gold standard, compression ultrasonography, CUS. You take the ultrasound probe and you press down on the vein. A normal vein collapses completely, wink, and it's gone. A vein with a thrombus in it acts like a rigid pipe. It won't collapse. That non-compressibility is diagnostic.
And for the ICU folks, there's a specific protocol I should mention.
The BLUE protocol, bedside lung ultrasound in emergency. Part of that protocol involves scanning the femoral and popliteal veins in any patient with acute respiratory failure to look for a DVT as a cause of their potential PE. It's becoming a mandatory skill for intensivists.
Okay, Part D, prevention and management. This is an exam favorite, isn't it? How do you prevent DVT in a surgical patient?
It is. And you have to divide your answer into mechanical and pharmacological prophylaxis. But before you even say that, you must mention risk stratification.
Right. Not one size fits all.
Not at all. You don't heparinize a 20-year-old having a tonsillectomy. You assess the risk first.
Okay, let's start with mechanical.
The simplest and most physiologic method is early mobilization. Get the patient moving. It restores that muscle pump. For patients who can't move, we use graduated compression stockings, or GCS, to reduce venous stasis.
And intermittent pneumatic compression. The squeezy boots.
The IPCs, these are absolutely crucial. They mimic the muscle pump, which increases blood flow velocity. But here is a deep dive fact for you. They also have a fibrinolytic effect.
Oh, that's interesting.
The mechanical squeezing actually stimulates the endothelium to release factors that help break down clots. So it's not just plumbing, it's actually changing the local biochemistry.
Wow.
And that's why IPCs are the go-to choice for patients with a high bleeding risk, like neurosurgery patients, where you absolutely cannot give heparin.
Which is a perfect segue into pharmacological prophylaxis.
The mainstays are heparins. Unfractionated heparin, UFH, usually 5,000 units subcutaneously 2 or 3 times a day. Or, more commonly now, low molecular weight heparin, LMWH, like enoxaparin.
And LMWH is generally preferred.
Yes, because it has much better bioavailability, and you can usually give it just once a day. It's more predictable.
So why would you ever choose unfractionated heparin if LMWH is easier?
Renal failure, that's the key exam answer. LMWH is renally excreted, so if a patient has severe kidney failure, let's say a creatinine clearance less than 30 milliliters per minute, LMWH can accumulate and cause major bleeding.
And UFH isn't.
UFH is not cleared by the kidneys, so it's safe in renal failure. Also, UFH has a short half-life and is easily reversible with protamine. So if you think the patient might need to go back to surgery urgently or might bleed, UFH gives you more control.
That is a crucial distinction. What about heparin-induced thrombocytopenia, HIT? Is that relevant here?
Very relevant. It's a completely paradoxical prothrombotic state. You give heparin, but antibodies form that activate platelets. So the platelet count drops, but the patient clots more.
That's terrifying.
It is. If a patient on heparin suddenly drops their platelet count by 50% or develops a new thrombosis, you must stop all heparin immediately. And you cannot switch to LMWH because there is cross-reactivity. You have to switch to a different class, like a direct thrombin inhibitor, argatrobin, or bivalirudin.
That's a high-level point that would definitely impress an examiner. Now let's briefly touch on management of an established DVT before we hit the big anesthetic implications.
Sure. The goal is to prevent the clot from getting bigger propagation and breaking off embolization. So we anticoagulate immediately with heparin, either LMWH or UFH, and then we bridge to an oral maintenance drug like warfarin or one of the newer direct oral anticoagulants, the DOACs like rivaroxaban.
But what if they can't have blood thinners, say a trauma patient with a brain bleed who then develops a DVT?
Then you need an IDC filter. It's essentially a little metal basket that you place in the inferior vena cava to catch any clots before they can hit the lungs. It's a safety net.
Okay, now for the most critical section for our listener. Part E, anesthetic implications. This is the core of that 20-mark question. Discuss the anesthetic management of a patient with DVT.
Let's break it down. Pre-op, intra-op, and post-op. Pre-operatively, if you have a patient scheduled for elective surgery, say a hernia repair, and you diagnose an acute DVT, what do?
You cancel.
Correct. You delay the surgery. You cannot take an acute, untreated DVT into an elective surgery. The risk of PE is just way too high. You treat them with anticoagulants for at least 3 months, allow that clot to stabilize and adhere to the vessel wall, and then you reconsider.
And what if it's an emergency? A fractured neck of femur with a new DVT. You can't wait 3 months.
Then you have to proceed, but with extreme caution. You might place an IVC filter pre-operatively, and your anesthetic technique becomes very, very controversial.
Let's talk about that technique, regional versus general.
The big scary risk with regional anesthesia, specifically neuraxial, so spinal or epidural, is the hematoma. If the patient is fully anticoagulated for their DVT, a neuraxial block is generally contraindicated. You risk an epidural hematoma, which can compress the spinal cord and cause permanent paraplegia. It's a catastrophe.
This is where the ASRA guidelines come in. We need to be specific about the hours, don't we?
Yes. You must quote the guidelines. Let's take LMWH. For prophylactic doses, the low dose, you typically need to wait at least 10 to 12 hours after the last dose before putting a needle anywhere near the spine.
And for a treatment dose?
For therapeutic doses, the high dose used for treating an active DVT, it's 24 hours, a full day.
And what about catheter removal? It's not just about putting it in.
Good catch. You can't just pull an epidural catheter out whenever you want. The same rules apply. You usually wait 10 to 12 hours after the last prophylactic dose to pull the catheter. And then, this is the mind the gap part, you wait another 2 hours at least after removal before giving the next dose of LMWH.
So there's a window of safety.
A critical window of safety to prevent hematoma formation during the trauma of catheter removal itself.
Okay, so let's say we decide to go with general anesthesia because the patient is anticoagulated. What are the intraoperative risks we need to worry about?
The biggest risk is dislodging that clot. Positioning is key. If you put them in lithotomy, avoid extreme hip flexion, which can kink the femoral vein. Be very, very careful with tourniquets. If you exsanguinate a limb with an Esmarch bandage and there is a clot there, you are literally squeezing that clot into the central circulation.
Like the terrifying image.
It happens, and how would you know? Intraoperative PE. The patient is under GA. You can't ask them if they have chest pain.
You have to watch the monitors like a hawk.
Specifically the capnography. You'll see a sudden, unexplained drop in end-tidal CO2. The CO2 just falls off a cliff.
Can we just quickly explain the physiology of that drop? Why does the CO2 go down if the patient's metabolism hasn't changed?
It's dead space. It's all about dead space. The clot travels to the lungs and blocks blood flow to a segment of the lung. The ventilator is still pumping air in, but there's no blood there to exchange CO2 with.
So the air coming out is just air.
Exactly. The air coming out of that segment has zero CO2. When that mixes with the rest of the air from the healthy lung, the average FeCO2 plummets. That triad hypotension, desaturation, tachycardia, and a sudden drop in FeCO2 is PE until proven otherwise.
And if that happens, what's the immediate management?
ABC, 100% oxygen. Support circulation fluids and inotropes, specifically focusing on right heart support because the RV is failing against that new blockage. Think noradrenaline or vasopressin. And if it's catastrophic, you might need thrombolysis on the table or even a surgical embolectomy, but those are really desperate measures in a surgical patient who's already open.
Okay, let's talk about special situations.
Yeah.
Pregnancy. DVT in pregnancy is so tricky.
Very tricky. Your D-dimer is useless because it's high in a normal pregnancy anyway. You can't use warfarin because it's teratogenic. It causes bone defects in the fetus. So LMWH is the drug of choice.
This doesn't cross the placenta.
Correct. It doesn't cross the placenta. You treat them throughout the pregnancy and for at least 6 weeks postpartum.
And what about anesthesia for the pregnant patient who has a treated DVT for delivery?
Well, if they're on therapeutic LMWH, they might not be eligible for an epidural for labor analgesia because of that 24-hour rule. This is a major counseling point. You might have to switch them to UFH near term, which has a shorter half-life, or they have to accept that they might need a general anesthetic if they need an emergency C-section and the timing isn't right.
That's a real clinical dilemma. Okay, another special situation. Trauma.
Trauma patients are the definition of high risk, but they're also high bleeding risk. They often have pelvic fractures, liver lacerations. You can't just heparinize them.
Right.
This is where IVC filters and aggressive mechanical prophylaxis like IPCs are absolutely vital. Also remember, spinal fractures might prevent you from putting IPCs on the legs if there are lower limb fractures too. In that case, you might need to use foot pumps instead.
Okay, Part F, complications. We've talked about PE, which is the acute killer. But what about the long-term consequences?
Post-Thrombotic syndrome, PTS. The clot, even after it resolves, damages the delicate valves inside the deep veins. So years later, the patient has chronic swelling, pain, heaviness, and skin changes like stasis dermatitis or even venous ulcers. It's a major cause of chronic morbidity. It affects quality of life massively.
And we shouldn't forget chronic venous insufficiency.
Correct. It's the long-term sequela. The leg just never quite returns to normal because that venous pump is permanently compromised.
And regarding ICU care, what's our role post-operatively?
Vigilance. In the ICU, patients are sedated. They can't tell you their calf hurts. You have to be proactive. Daily assessment of the limbs, ensuring the IPCs are actually on the patient and switched on, not just hanging on the bed rail. And coordinating mobilization. We need to work with the physiotherapists to get these patients moving, even passively at first, as soon as it is safe.
Now, Part G, exam integration. Let's bring this all together for the student. How do we compare DVT and PE in an exam? This is often a compare and contrast question.
Think of them as the same disease, VTE, just in different locations. So you draw a little table.
Legs versus lungs.
Local pain and swelling versus systemic dyspnea, shock, and hemoptysis.
For DVT, it's don't dislodge it. For PE, it's resuscitate the right heart. If you structure it like that, the examiner can see you understand the whole spectrum.
And the Viva traps. What are the common things students say that make examiners just roll their eyes?
Trap number 1, relying on Homan's sign. Just don't even mention it. Trap number 2, saying, I'll examine the leg to rule out DVT. Remember, 50% are asymptomatic. You can't rule it out.
Being vague about spinal anesthesia and anticoagulants, you can't just say it's risky. You need to know the hours. Prophylactic versus therapeutic timing, it depends, is not an answer unless you explain what it depends on.
Good point. And for the diagrams, if I'm writing a long answer, what should I draw?
You must draw the Virchow's Triad triangle. Label the corners: stasis, hypercoagulability, endothelial injury, and put a few examples next to each corner. Then draw a simple algorithm for diagnosis. Suspected DVT leads to Wells score, which leads to either D-dimer or ultrasound, and maybe a flowchart for prevention. Risk assessment leads to low risk, ambulate, versus high risk, LMWH plus IPC.
That makes the paper look so professional and organized. Structure is everything in a 20-mark answer.
Absolutely. Presentation matters. If the examiner sees Virchow's triad drawn clearly on the first page, you've already passed the first hurdle in their mind.
Okay, let's zoom out to the big picture summary. If you had to summarize the key take-home points for the exam, the things that absolutely have to be in the conclusion of the answer, what are they?
Let's list them out.
Virchow's triad is the pathophysiology anchor. Always start there.
Orthopedic surgery, trauma, and cancer are the top killers regarding DVT risk.
50% of DVTs are asymptomatic. Clinical signs are unreliable. Ultrasound is the key to diagnosis.
Prevention is better than cure. Mobilization plus LMWH plus IPC risks stratify every single patient.
Anesthesia management is all about safety. Respect the anticoagulant timing for neuraxial blocks.
Be vigilant for intraoperative PE watch, that ATCO2.
That's a fantastic summary. I'd add a model conclusion sentence for the written exam. Something like, in conclusion, DVT is a common and preventable perioperative complication with potentially fatal consequences. The anesthesiologist plays a critical central role in risk stratification, prophylactic management, and the safe timing of neuraxial interventions.
Perfect. That sounds like a senior resident or a consultant speaking.
Yeah.
Clean, confident, and correct.
Before we sign off, I want to leave our listener with a provocative thought. We talked about how DVT can be silent. We talked about how PE can be sudden.
Yes.
Consider this. In many cases of sudden death or failed resuscitation in the hospital, a massive PE is found at autopsy. It makes you wonder, how many times do we treat refractory hypotension or a cardiac arrest without realizing the primary cause is a clot we never saw coming? It really emphasizes the need for high vigilance and maybe a more aggressive, routine use of bedside ultrasound in our daily practice.
Absolutely. The probe is the stethoscope of the 21st century. Mastering the detection of a DVT or signs of right heart strain could save a life that otherwise just looks like a mystery collapse.
Well, that brings us to the end of this deep dive revision session. We know the material is dense, but mastering Virchow's triad really does unlock the answers to almost any question on this topic.
Good luck with the exams. You've got this. Go in there, be confident, and watch out for those Viva traps.
Until next time, keep diving deep.